Good evening, everyone, and thank you for joining us for tonight's International Dermatology Education Foundation Educational Series webinar. My name is Ashley with RBC Consultants, and the title of tonight's webinar is Clinical Updates for WINLEVI Cream 1%. As moderator this evening, we have Dr. Leon Kircik. He is president of the International Dermatology Education Foundation, clinical professor of dermatology, Icahn School of Medicine at Mount Sinai, New York, adjunct clinical professor of dermatology, Indiana University School of Medicine in Indianapolis, Indiana, and medical director of physician skincare, DermResearch, and skin sciences in Louisville, Kentucky. As speaker this evening, we have Dr. Hilary Baldwin from the Acne Treatment and Research Center, Rutgers Robert Wood Johnson Medical Center in New York, New York. We would like to thank our supporter this evening, Sun Pharma, for making this educational event possible. Before we begin, a few logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues, please submit your questions in the question pane on the right-hand side of your screen. At the end of this webinar, a survey will pop up in your browser and will also be emailed to you within 1 to 2 days. We would greatly appreciate it if you could fill in this short survey. And finally, within 1 to 2 days of the webinar, a certificate of attendance will be emailed to you. We will have a Q&A at the conclusion of this event, and so if you have any questions, please submit your questions using the question pane on the right-hand side of your screen. Now, without further ado, I would like to pass the floor virtually to Dr. Kircik.
Thank you, Ashley, and greetings from Amelia Island at CCD meeting. So I'm very happy to be here tonight for another series of International Dermatology Education Foundation. As you know, IDEF is a nonprofit organization whose principal mission is to raise awareness and improve dermatology care all over the world through education, especially in underserved areas. We have done several programs and we have come to your homes actually through the webinars since the pandemic. And as you have seen, we have been all over, not only in North America, US and Canada, but also in South America, in Southeast Asia and Europe. Tonight, we have a special guest. Meanwhile, please do follow us on social media, including on Facebook, Instagram, and so on. And tonight, we have a very special guest, a good friend of mine, my mentor from Brooklyn, New York, Dr. Hilary Baldwin, who is what I call her the queen of acne and rosacea. Welcome, Hilary.
Oh, thank you very much, sir. It's such a pleasure.
And she's going to give us the clinical updates for WINLEVI Cream 1%. Thank you, and take it over.
Okay. It's a pleasure to be here tonight. I'm coming to you from Brooklyn, New York. We're going to talk a little bit about clinical updates for WINLEVI, which, as you, of course, know, is clascoterone 1% cream. And we're going to see that it's the first and only topical androgen receptor inhibitor. So cool stuff. Hold on 1 second, please. Hang on. Technical difficulties. There we go. So this program, of course, was developed by Sun Pharma, and I'm presenting on behalf of them. And I'm going to be giving you the presentation, which is consistent with the full prescribing information for WINLEVI. This is not a CME program. This is a promotional program, so I'm going to follow the rules. At the end, we're going to be answering any kind of questions that you have. And if the questions are off-label or talking about combination therapy, we won't be able to answer them on this platform. But feel free to ask any questions you have. And if it's something that I can't answer, we'll go ahead and turn it over to the medical department to get back to you with an answer to your question. And I have received compensation to give this presentation. So this is our agenda for tonight's talk. First, we're going to talk about the skin as an endocrine organ. We don't often look at the skin in this way, but we're going to see how that's very important to the pathophysiology of acne. Then we're going to talk about targeting all 4 pillars of acne pathogenesis, understanding clascoterone itself, and finally looking at the efficacy and safety data for clascoterone. So let's start off with the topic of skin as an endocrine organ. When we think about acne, we recognize the organs we're talking about, right? The adrenal glands, the gonads, but we don't often think of the skin as being an endocrine organ. But as you can see shaded here in blue, the face as well as the upper chest and upper back, the sebaceous glands in that location are tiny little endocrine organs, and they contribute to acne in all patients, men and women. And they grab a hold of the precursors of androgens floating through the bloodstream in the vicinity of the sebaceous gland, and they actually possess all 6 of the enzymes necessary to convert the androgen precursors like DHE and DHEAS into the more potent androgen DHT. And DHT, of course, is the form of the androgen hormone, which is going to bind to the androgen receptor and create all the mischief downstream, which includes inflammation as well as an increase in the production of sebum. And this, of course, is occurring approximately at the time of menarche or during the beginning of puberty. So this androgen receptor activation is actually the initiating feature in acne. When we enter into puberty, our sebaceous glands, which have been asleep our entire lives, there but asleep and not producing sebum, wake up under the influence of androgens and start producing sebum. So that is the initial foundational step in acne pathophysiology. So that stimulates an increase in sebum production. And since C. acnes eats sebum for breakfast, lunch, and dinner, an increase in sebum serves as a nutrient for C. acnes, increasing C. acnes proliferation within the follicle. C. acnes is what's inducing the inflammatory process. In addition to that, the activated androgen receptors increase inflammatory cytokine production as well, also adding to the increase in inflammation that we see in acne. Aside from that, we also have follicular hyperkeratinization. Now you notice that that circle is sitting all by itself without an arrow leading to it. And that's because we're not fully sure of why the follicular hyperkeratinization occurs only in the follicles of people with acne, only in the follicles of the follicle that happens to have acne at that time in that patient. We do think, though, that it's related to sebum as well, that an increase in sebum is increasing the production of C. acnes by feeding the little suckers, but that there's a difference in the quality of the sebum, and the quality of the sebum increases the hyperkeratinization within the follicle, sort of making it much more sticky, shall we say, leading to the hyperkeratinization and the follicular occlusion, which, along with the increase in inflammation that we just talked about, results in the formation of the acne lesion. So we have here our 4 pillars of acne pathophysiology, starting with the increase in sebum, then C. acnes proliferation, increase in inflammation, and hyperkeratinization. And when we want to treat our patients as well as we possibly can, we want to hit as many of those 4 pillars of acne pathophysiology that we possibly can. The more we hit in general, the better the patient does. So we want to address all 4 pillars of acne pathogenesis. Now, how do we know this? Well, we know this through many studies, culminating in the AAD 2024 guidelines for acne management, saying that topical therapies are the foundation for all degrees of acne severity, from mild disease, moderate disease, and severe disease. And the combination of topical agents to target all those different aspects of acne pathogenesis are recommended. So prior to the approval of clascoterone, there was no topical therapy that addressed that androgen-induced excess sebum production. So we had medications that took care of the other 3 pillars, the increase in C. acnes, the increase in sebum, the increase in C. acnes, the increase in inflammation, and the follicular hyperkeratinization, but we did not have a topical therapy to address the androgen-induced excess sebum production. We had orals, but no topicals. So here we're looking at the topical medications that are available for treating acne, and we can see inhibition of the androgen receptor, antibiotics, retinoids, benzoyl peroxide, and azelaic acid as the columns, and their ability to hit those four pillars: the hyperkeratinization, inflammation, C. acnes proliferation, and sebum production. As you can appreciate, the only medication that we have topically that reduces sebum production is WINLEVI in the yellow down at the bottom. WINLEVI also decreases the pro-inflammatory cytokines, so it's also in the box for inflammation. So if we're trying to come up with a combination therapeutic regimen that attacks as many of these four pillars as possible, WINLEVI is definitely a part of that plan because it's our only topical that decreases sebum production. Please note that there is no check in the box for topical retinoids. Isotretinoin oral retinoids do decrease sebum production, but topical retinoids do not. And this is an old wives' tale that I come across very frequently. I think it's because retinoids cause patients to become dry and flaky as part of their process of decreasing the cohesion of the outer layers of the stratum corneum. And people just sort of assumed that since the skin was dry, that must mean that it's a reduction in sebum. But there is no reduction in sebum caused by the use of topical retinoids. So again, WINLEVI, the only topical inhibitor of sebum. Now, orally, of course, we have oral contraceptives and spironolactone and isotretinoin. But if we're trying to put together a topical regimen, WINLEVI is the name of the game for reducing sebum production. Sorry, it's taking a while to advance. There we go. So now we're going to take a look at a video that goes over this as well.
Presenting as papules and pustules on the skin is caused by the blockage and inflammation of pilosebaceous units, primarily on the face and upper trunk. Acne is triggered by an increase in androgens, whether due to circulating androgens or those synthesized within the skin. These androgens stimulate the sebaceous gland, beginning at puberty in both females and males. Androgens such as dihydrotestosterone or DHT bind to androgen receptors in sebocytes. The receptor then translocates into the nucleus, dimerizes, and initiates the transcription of androgen receptor target genes, activating the androgen sebum pathway. This increases sebum production and cytokine release, promoting inflammation. As a result of increased androgen activity, excess sebum serves as a nutrient source for Cutibacterium acnes, increasing proliferation and consequently inflammation and follicular plugging due to hyperkeratinization, leading to comedone formation. Androgen stimulation increases sebum production, initiating C. acnes bacterial growth, inflammation, and hyperkeratinization, resulting in acne vulgaris. Therefore, the androgen receptor in the sebaceous gland is an effective therapeutic target to inhibit the acne cascade.
So now that we understand better the pathophysiology of acne and the reason why we're talking so much about the androgen sebum pathway, let's talk about clascoterone in specifics. So here we see clascoterone in the top picture, and you can see that it bears a striking resemblance to both dihydrotestosterone and, for that matter, spironolactone as well. So they all have this fused four-ring backbone that's key for the ability for the medication to bind to the androgen receptor. So as we're going to see in a moment, clascoterone is going to compete with dihydrotestosterone for that receptor site. So of course it has to look a lot like it, right? It has to park in the same parking space that dihydrotestosterone would park in. So clascoterone is going to competitively bind to the receptor and then block the androgen DHT binding. So here we see the DHT in the pink, which was binding to that androgen receptor site that's now being taken up by clascoterone. Since I'm from New York, I think of this in terms of parking spaces. There are limited numbers of parking spaces in here. DHT wants to park in that spot, but clascoterone has already done so. So DHT cannot do its normal activity of increasing sebum production and increasing pro-inflammatory cytokines, and sort of floats away in the atmosphere and metabolizes and does not get used. So we block that production of sebum and the production of pro-inflammatory cytokines. So clascoterone here is binding to that androgen receptor, inhibiting androgen receptor activity, inhibiting DHT-induced lipid synthesis, and inhibiting DHT-induced inflammatory cytokine secretion. So very simple mechanism of action that blocks the what DHT normally does, and DHT, of course, the most important hormone in this whole story of acne. So now that we understand how it works, let's take a look at the pivotal phase 3 trials in patients with acne. But you know what comes next, right? We can't start talking about efficacy or tolerability until we pay homage to the FDA and look at the important safety information. So there are no contraindications for WINLEVI. The warnings and precautions include local irritation, and we're going to look into that in great detail, and we're going to find that there's very little, but we're going to go over that in detail, looking at the possibility of pruritus, burning, redness, or peeling. We're going to talk a little bit about the HPA axis suppression. Give me 1 second to do that, and hyperkalemia. I'd like to start here with hyperkalemia. This was an issue for the FDA when the medication first came out because of the similarity, as we saw previously, between clascoterone and spironolactone. And you're well aware that spironolactone is a potassium-sparing diuretic. And initially, with its use, we were concerned that perhaps if we used it in acne, that patients would become hyperkalemic and it would cause cardiac irregularities. Now, we know that in 3 very large studies, very well-conducted studies, we now know that spironolactone in young, healthy individuals at 100 milligrams or less does not cause hyperkalemia. So we really wouldn't expect WINLEVI, which is not systemically absorbed, to do so either. But the FDA did require them to go back in the safety study and make sure that hyperkalemia was not an issue, and it was not. You can see here increased elevated potassium levels in 5% of WINLEVI and 4% of vehicle-treated subjects. So the FDA did not require evaluating potassium levels moving forward in the phase 3 trial, or indeed in your patients. The HPA axis suppression story was one of a discussion of the metabolism of clascoterone. Clascoterone is an androgen receptor inhibitor, but it is metabolized into cortexolone, which is very early in the cortisol pathway in every cell in our bodies. So the FDA said, well, you know, you're in the cortisol pathway, you have to show us that you do not cause HPA axis suppression, right? So they did a study with 42 individuals, 22 adolescents, 20 adults, and they found that 5% of the adult subjects and 9% of the adolescents at day 14 had very slight HPA axis suppression. Now, importantly, this study was maximum use. It was 6 times the normal amount of WINLEVI applied to the surface of the skin, creating a very slight suppression in only 3 people. And 4 weeks after stopping, everything returned back to normal. So the FDA, again, was not concerned about this, did not require this to be evaluated during the phase 3 clinical trial, and it is not recommended that you need to do so in your patients. So that explains all of the warnings and precautions on this slide. The adverse reactions, again, we're going to look into in detail, looking at the possibility of redness, pruritus, scaling, or dryness. So finally, we can start talking about the efficacy of WINLEVI in the phase 3 trial. So what we're looking at here is treatment success versus vehicle, all along the way from week 0 to week 12. Now, it's important to recognize that treatment success means getting all the way to clear or near clear. with monotherapy. So this is not combination therapy. This is just WINLEVI as a standalone, used twice a day on the patients. And we can see that at the end of week 12, we've got about 20% of people getting all the way to treatment success. Now, some of these people started off with severe disease, which means in 12 weeks they had to go from severe to moderate to mild, all the way to clear or near clear. It's a very tall order for monotherapy in such a short period of time. One of the most important things on this slide that I want you to recognize is the huge increase in the IGA success percentage between weeks 8 and 12. As you can see, by week 4, there is no statistically significant difference between WINLEVI and vehicle. There's a slight difference at week 8, and then WINLEVI takes off like a rocket. Look at the slope of the line of the increase in success between week 8 and week 12. With a success, certainly that slope is continuing on. It looks as if it's got legs, as if the study was a little bit longer. Perhaps the number would have been even higher, but this is the data that we have. So at week 12, we see 20% of people getting all the way to clear or near clear without concomitant medication. Now, that doesn't mean that people aren't getting better along the way. That just means that reaching all the way to clear or near clear is taking place primarily between week 8 and week 12. Here we see reduction of inflammatory lesions on the top and non-inflammatory lesions on the bottom, and you can see a nice reduction in both inflammatory and non-inflammatory. You can see it there at week 4. It's already at the patient has already lost 32 and 18 lesions. So at the end, a 46% reduction of inflammatory and a 31% reduction of non-inflammatory lesions. So on the preceding slide, I did not mean to suggest that those patients were not getting better before week 8. They just had not yet reached the promised land of clear or near clear. They did have a reduction in both their inflammatory and their non-inflammatory lesions along the way. So a couple of pictures to share with you. 2 patients on the left. We see baseline and week 12 for a female patient from the WINLEVI clinical trials with a significant reduction of inflammatory lesions. That looks like a severe case to me at baseline with a lot of post-inflammatory change, and by week 12, a nice resolution of lesions as well as the hyperpigmentation. On the right, we see a male patient with lighter toned skin with a reduction of the erythematous inflammatory lesions from baseline to week 12. Again, these photographs are with monotherapy. So now let's look at the flip side of the coin. We looked at efficacy. Now let's take a look at the safety profile at 12 weeks. And most of what we're talking about with acne medications, when we say safety, what we really mean is cutaneous safety, irritation, redness, stinging, burning, that sort of thing. So here we're looking at treatment emergent AEs, adverse events that occurred during the treatment phase. And you can see the number is quite low. 11.1% for WINLEVI, 12.8% for the vehicle. So there's actually fewer AEs in the WINLEVI group than in the vehicle group. In the right, in the call-out box, you can see most of them were nasopharyngitis, headache, and oropharyngeal pain. That there was no severe treatment emergent AEs and no systemic adverse events specifically related to that HPA axis suppression that we talked about before. And down at the bottom, you see that although 11.1% of patients experienced something, 76% of that something was mild, 24% was moderate, and again, there were no severe treatment emergent AEs, so very well tolerated. You know, as I mentioned before, clascoterone is rapidly metabolized in the skin into cortexolone, and that was the reason why we had to look at HPA axis suppression. But cortexolone is devoid of systemic or topical anti-adrenergic effects and is very, very weak glucocorticoid. The importance of noticing this rapid metabolism within the skin is that that's what makes this product safe for use in men. So within the skin, the clascoterone is converted into cortexolone. So clascoterone never enters into the systemic circulation. For that matter, cortexalone does not either. During the phase 3 trial, cortexalone levels were measured and they were non-detectable. 38% of subjects during the WINLEVI trials were male, and this is a medication that is safe for use in both females and males. So we talked before about how the skin itself is the endocrine organ. That's where the conversion is taking place to DHT. So it doesn't matter what your circulating level of androgens are. This is a product that works at the level of the sebaceous gland, and that is the same thing in men as it is in women. So this is going to work for both your male patients and your female patients, your older patients and your younger patients. Part and parcel, though, of the rapid metabolism in the skin is seen in the pie graph over on the right. So you can see that after 6 hours of incubation in human plasma in an in vitro trial, most of the clascoterone is gone, and most of it has been converted into cortexalone. So the flip side of this is that since it's so rapidly metabolized, it disappears relatively rapidly. So, and we don't want that to happen, obviously, because that means that sebum might be starting to be produced again. And what this shows us is the rationale for this being a BID drug. You need to put it on twice a day so that you're suppressing the mechanism, producing both sebum and pro-inflammatory cytokines over the entire 24-hour period of time. So this is a BID drug. It's very important that we tell this to our patients. This is not a drug to be added on as a once a day. You know, the patient's regimen is too complicated. We'll just throw it in for once a day. That's not the way that this drug works. It's a twice a day drug, and that's the key to controlling that androgen-induced sebum production without having to use an oral medication. So local skin reactions are looking specifically at redness, scaling, dryness, itching, stinging, and burning. And you can see here that the incidence of new or worsening local skin reactions seen in more than 4% of subjects were these 4 areas. But if we look at WINLEVI in the center and vehicle over on the right, you can see that in some cases, the vehicle caused more of a problem with erythema, scaling, pruritus, stinging, and burning than did the WINLEVI itself. So very well tolerated, and we see the percentage within the parentheses very low, and over on the right, that low number was also primarily trace or mild in severity. So very few people having trace or mild in severity local skin reactions with WINLEVI. So it's taken out for a spin also for a long-term extension study. So the patients who were enrolled in the original phase 3 trial, which was 1,440 patients, were asked as they approached the end of the phase 3 trial, would you like to continue on to an open label study? In other words, everybody gets drug. There is no longer a vehicle involved. And 600 people said, yes, thank you very much. I would like to do that. And you see the study design over on the right. So for the first month, everybody who entered into the trial received WINLEVI twice a day. Now recognize that half of those people had been on WINLEVI already during the phase 3 trial, and half of them were on vehicle during the phase 3 trial. So everybody's on it now for the first month, twice a day. And then at months 1, 3, 6, and 9, they're evaluated. And if they're doing well, if they're clear or near clear, they're taken off treatment. And if they're doing mild, moderate, if they're rated as mild, moderate, or severe, they're put on it or kept on it. So people are coming on and off all during this extension trial till the end of the study. So let's look at the treatment emergent AEs now in the long-term safety profile. Remember, the number was 11.1 in the phase 3 trial, and now it's 18.1. So you might be thinking, oh, wow, there's more treatment emergent AEs in the long-term safety study. Maybe this is an issue. But treatment emergent AEs are everything that happens to a patient in the course of the study. So if people come into the study center and they got into a car accident, they had an abscessed tooth, a bunionectomy, anything that happened to them, heart attacks, sickle cell crises, all of that is included. So here in the long-term study, they've got 40 months to have a cold, to get COVID, right? So yeah, the number goes up a little bit because it's 3 months at 11.1 and another 6 months at 18.1. So this is a very low number. It is not an increase in the side effect potential over time. Once again, most of these AEs were nasopharyngitis, respiratory tract infection, and sinusitis. There was no accumulation or increase in treatment emergent AEs over time. And once again, there was no evidence of that HPA axis suppression that we were talking about previously. So very well tolerated. Also, in terms of local skin reactions, they were getting back to looking specifically at the skin, scaling, dryness, redness, and itching. In the patients who had been in WINLEVI the whole time on the left, those who had been on the vehicle on the right, within the parentheses, we see the irritation that occurred, very low number, and once again, primarily traced to mild. Now, what I didn't tell you was that in the long-term safety study, in addition to putting it on the face, they also were allowed to put it on their trunk, the entire back, the entire chest, and the upper arms, if they had acne in those locations as well. So they had to do the face, but they could do the trunk. So that's important for a safety study, right? You want the patients using a large dose to make sure that indeed the safety is there. And as we just saw, it was. So looking at the flip side of the coin of this long-term safety study, this is efficacy. So here we're looking at IGA scores again, which is getting all the way to clear or near clear. And we see baseline on the left, all the way up to 9 months on the right. The various colors are kind of complicated. I think it's easiest just to take a look at that arrow and to look at the slope of the arrow. Remember at the end of the phase 3 trial when we said the slope of that line was kind of like a rocket and it looked as if the drug still had legs, and if the trial had gone a little bit longer, maybe there would have been even more patients reaching clear or near clear? Well, that's what we're seeing here. Over time, the patients continue to improve. And by 9 months, we see 50.3% of patients all the way to clear or near clear. So this is a drug that takes a little bit of a sweet time getting started, but once it gets started, it continues to show improvement over time. So it's one of the drugs where we really have to get out our pom-poms and say, just stick with it. Within a short period of time, you're going to reap the benefits of having stayed with the medication. And here we're looking at truncal, clear or near clear. The slope of this line is even more steep. And at the end, 52.4% of patients achieved an IGA score of clear or near clear. Now, truncal is interesting, isn't it? Because what else do we have topically for treating the trunk? We have benzoyl peroxide that bleaches. We have minocycline that causes staining of the skin. We have topical retinoids that are often quite irritating. So with WINLEVI, we've got a truncal medication, which is highly effective. It doesn't bleach, doesn't stain, and doesn't irritate. So we have a little bit of a clinical update to tell you about, and this came about because our patients kept telling us that WINLEVI was very moisturizing. And so some took this out for a spin, and they looked at 80 adult subjects who were given the WINLEVI on one side of the face and nothing on the other to use twice a day. So one half of the face untreated, one half of the face treated with WINLEVI twice a day. They were not allowed to use other skincare products. And both sides of the face were assessed at baseline and then again at 24 hours, week 1 and week 2. So they looked at tolerability, both in terms of what the investigator thought as well as what the patient thought, and also looked at corneometry and transepidermal water loss. So corneometry measures skin hydration, how well hydrated is the skin, and transepidermal water loss looks at evaporation. Now, the skin isn't supposed to evaporate. If our stratum corneum is doing its job, transepidermal water loss should be nice and low. But when we use acne medications that cause a perturbance of the stratum corneum, often transepidermal water loss is greatly increased. So that's the reason for looking at these two clinical endpoints. So here we're looking at corneometry. And again, that's measuring hydration of the skin. The higher the bar, the better. So WINLEVI is in blue, untreated is in gray. So you can appreciate at all 3 time points, 24 hours, 1 week and 2 weeks, there was a significant increase in corneometry scores. Okay? So there was better hydration of the skin. The patients were right. They told us it felt moisturizing, and indeed it was. Now let's look at transepidermal water loss. So here we're seeing no difference between the WINLEVI and the untreated, and they're thinking, gosh, why are they showing me a study that doesn't show any difference? Well, that's because it's kind of impressive that WINLEVI doesn't damage the skin barrier. If we had, for example, benzoyl peroxide on this slide, it would be very high. If we had a topical retinoid, it would probably be off the screen that you're looking at. So the fact that it did not damage the skin barrier like most acne medications do is a really big deal, right? It's big news. So what about the tolerability assessment? Well, both the patients and the investigators said there was no dryness, no tightness, no stinging, itching, or burning, no difference between the 2 sides of the face as far as either the investigator or the patients were concerned. So overall, the patients rated the tolerability of WINLEVI as excellent. So in summary then, treatment with WINLEVI, as we saw in the slide deck, is a way to safely inhibit the androgen sebum pathway in both men and women. We see a significant improvement in IGA, the global assessment versus vehicle at week 12, a significant reduction in lesion counts, both inflammatory and non-inflammatory, over the course of the 12 weeks. Continuous improvement in IGA success with long-term use. We saw that the slope of the line still hadn't started to flatten out yet, suggesting that there's legs even at the end of the first year. And it maintains skin barrier integrity and provided moisturization in the 2-week split face clinical trial that we just looked at. So, unfortunately, I have to pay homage to the FDA again, although in truncated form. So we saw no contraindications. We saw warnings and precautions that looked at local irritation. We saw very little. We saw that HPA axis suppression, according to the FDA, was nothing that we needed to be concerned with, that hyperkalemia did not occur either, and that adverse reactions were few and mild in severity. So that's all I have to say in terms of my prepared remarks, but I'm happy to answer any kind of questions that you might have.
So thank you, Hilary. And I was fascinated by the bunionectomy treatment emergent adverse events.
Anything, right? Getting hit over the head with a baseball bat is my favorite.
Right. I usually use the example of kid falling from the tree or falling from bicycle, but I've never thought about bunionectomy. I love it.
The first thing that came to my mind.
We have a couple of questions, actually. One is, this comes up quite often, about the QD versus BID use of clascoterone. Can you comment a little bit on that? We know the FDA approved use is twice a day, but patients find it difficult. Tell us a little bit what you think.
Yeah, well, in the phase 2B clinical dose ranging study, it was they looked at QD and BID, and it was very clear that BID gave a much better result than QD. So if you're looking for good results, you really need to be doing the twice a day. And there's a rationale for it, because it's suppressing sebum production for a relatively short amount of time each time it's applied, thanks to that rapid conversion. So that rapid conversion is sort of a double-edged sword, isn't it? It means that it's safe for use in men, but it also means that it goes away fairly rapidly and needs to be used twice a day. So I think if anybody on this webinar thinks that has not been terribly impressed, you need to make sure that you're telling them to use it twice a day and that they actually are, because it makes a huge difference, in my opinion.
Absolutely. Now, also, you did a wonderful job when you described the efficacy of the drug for week 4, week 8, and then you said it takes off like a rocket. Tell us, what do you think? And then when we look at the long term, we see all the way up to a year increased efficacy. What's going on there? Why is that steady increase in the efficacy of the over 12-month period?
Well, I have a theory. So there's no data to support my theory, but I have a theory. When you start putting WINLEVI on the skin of somebody who has acne, their sebaceous glands are chock full of sebum. And the WINLEVI is going to shut down the production of new sebum, but it's not like it's brushing all the sebum out of the follicle. That stuff has to go away. So what I'm envisioning is that it takes a couple of months for the sebum that's there to get used up and no sebum to replace it. So that's why it gets off to a slightly slow start, because after all, the other two medications that we have for treating acne that take a darn long time to work, like 3 to 6 months, are spironolactone and oral contraceptives, and they're working in part by the same mechanism of action. So I think it just takes a while for the sebum to go away, not to be replaced, before you actually can appreciate the effect of a reduction in sebum.
So that totally makes sense to me, and I'll buy that theory. I hope our audience will do as well. Knowing the pathogenesis of acne, and now we talked a lot about the sebum. So how would you start your treatment? What topical agents do you like to use or recommend?
Well, I don't think that WINLEVI is a standalone monotherapy drug. I think it is a foundational drug. We just discussed that sebum is a critical part of the acne process. In fact, we can go as far as to say no sebum, no acne. So I view WINLEVI as foundational to shut down the sebum production, and then add on top of it something to reduce C. acnes, something to reduce inflammation, to unclog the pores. So, but I think that, and since we saw that it takes a couple of months for it to get up to speed, it makes no sense to me for WINLEVI to be used after the fact. So I like it from the get-go, along with other medications that perhaps work a little bit faster, so that the patients can see improvement within the first month or two.
Okay, let's get back to the on-label here.
Okay.
But one thing is that, I think thinking about the sebum, controlling the sebum, is it controlling acne? Do you think controlling sebum is controlling acne?
Well, I think there's more to it than that. It's that's a little bit simplistic, but yes. If whenever we can shut down sebum production, patients get better. Spironolactone, oral contraceptives, isotretinoin shuts down sebum almost completely within a very short period of time, which is why it's so effective. So yes, I think that anything that we can do to either shut it down or to reduce the production of sebum is foundational in the treatment of acne.
Yeah, you did again a really great job about telling us, my line is the vehicles matter, and how this drug impact the epidermal barrier. You gave us the studies about the tool transepidermal water loss as well as the corneometry. Do you have, or do you know of any other vehicles in topical acne treatment that helps the moisturization just like this?
Well,
Are we aware of?
I would never presume to say that vehicles matter, Leanne. That's your expression, but vehicles make or break a product. The amount of active in our creams is extremely small compared to all of the excipients, and a product can be well made or poorly made. So yes, I think the vehicle matters a great deal. We saw that this vehicle is moisturizing. There's only one other type of vehicle that I know of that is actually moisturizing in and of itself, and that's the polymeric emulsion technology that some of our acne medications are in, which in and of itself reduces transepidermal water loss. So these are crucial. It's the reason why acne treatment in this day and age is so much better than it was when I was a kid. These products are not your grandmother's medications. They're well made with excellent vehicles.
I remember the topical tretinoins going back years.
Oh my gosh, just
The
fire.
gel.
Yes, oh my gosh. It's like pouring acid on your face.
Yeah. Well, I think let me see if we have any other questions that I'm able to see. Other than that, I think we can give. Oh,
Okay.
this is a good one. What is your sequence of application? Other topicals such as a retinoid and a sunscreen along with Levi. So just remind them, the audience, that we have to stay on label here, but let's just generally, what overall acne treatment, what do you suggest your patients to put things one on top of another, or the sequence is important, or even with the moisturizer use?
Right. Well, we're not really sure because most of them have not been studied. Of course, the combination of every moisturizer and every acne product hasn't been measured. But I often allow my patients to put moisturizers on before their acne products if their acne product is drying or irritating. So you have this moisturizing effect of the WINLEVI to help to create that nice smooth barrier. So as you said, I can't talk about combination therapy, but I think that made it clear what I would suggest.
Excellent. I thank you so much for your insight. As usual, that was great. I learned a lot, and I hope so did our audience. I thank you, our supporter, Sun Pharma, tonight for their continuing educational support. And since that we're done with Sun Pharma, let's see what's our next program here. Our next program is with Dr. Raj Chovatia. He's going to tell us clinical data and patient photos on an oral treatment option for adults with moderate to severe plaque psoriasis. And that is on June 3rd, this coming Tuesday at 7 p.m. Please tune in. I thank you so much. Have a good evening.